is secondary IOLs. It's a medley of cases I've put together. I'm actually a professor at a tertiary medical college, so I have a lot of my complication patients. I'm not saying that we all have a learning curve. So sometimes I get stuck up with these cases which I've got. So usually I have a few takeaway points. Whenever my colleagues or my residents have complication, they're always either blaming the cataract, that there was lens subluxation, the zonules were weak, or they're blaming the patient. So I think the first thing in learning I would say is that always learn to blame yourself. I mean, you're the surgeon, you're the pilot of the plane, and you're in charge of everything. In a drop nucleus, always insert the IOL in sulcus on rexis. When in doubt, don't insert the IOL and leave it for the retinal surgeon to plan. When the nucleus drops, please don't fish for chips. Go in the mid-vitreous and try to get those things out, because you'll cause a large dialysis and detachment. And a case which is potentially 6/6 with a good vitreous surgeon managing the case becomes a PL patient. Secondary IOL needs a good anterior and mid-vitrectomy. So I would like to say, just don't do an anterior vitrectomy. You require a good mid-vitrectomy also in these patients. Pars plana is the best approach for a vitrectomy, which gives you a good vitrectomy without traction, as Dr. Vasavada has always said. But always use an infusion cannula, because we usually, as anterior segment surgeons, don't realize the importance of having a formed globe when you're trying to fix these IOLs in the sclera. So either use an pars plana infusion or an AC maintainer. This is the technique which I felt has saved many a days. Like if the IOL is lying in the mid-vitreous, has not dropped all the way down, try to use the vitreous itself to levitate the IOL from the drop in the mid-vitreous and get it into the anterior chamber or in the iris plane, because there's a very simple maneuver I'll tell you. You just do a paracentesis and drain your aqueous, and the vitreous phase comes anteriorly and pushes the IOL and delivers it to you in the pupillary area. So this is my favorite sort of, you could say, a shortcut sort of a thing, which I like. PMMA insertion should always be tried in a patient. This is a PMMA non-foldable IOL. So in a patient this is the secondary IOL with a remnant of residual capsule, you have a lot of anterior lens capsule or some posterior lens capsule which has fibros. So try to find that place where there is remnant capsule. A single piece PMMA IOL will stay in the sulcus beautifully because of the length of the IOL, 13.5 millimeters, and the non-foldable material, the PMMA, the hard material. So this lenses, you gingerly place the haptic over the residual lens capsular complex which is there, and then either dial it very gingerly, or you can flex it from the side port over the area of the remaining capsule, and you can fix this IOL very well. So I think a PMMA single piece IOL can save many a day in these patients. And then you tap it very well and just see that it's stable, and these IOLs invariably stay very well centered because of the large size of the optic and the haptics, and it's a very stable eye. So this is my favorite IOL to go to, because after you've done a big vitrectomy and a half an hour, 45 minutes surgery, then you don't want to waste, like after you've removed the drop nucleus, drop pieces of the IOL, you don't want to spend time in doing suture support. So my AC IOL has been, the IOL has not got the respect it deserves. This is a Kelman multiflex IOL. When you do a very good anterior and mid vitrectomy and you have a deep anterior chamber, this IOL goes like butter. It just slides over the iris, and it's angle supported. I'm sure Dr. Keki Mehta has used a lot of these lenses, and Rayners used to make the best AC IOL, which they've unfortunately stopped making now. And in these patients, always make the haptic horizontal, because you don't want the upper lid to sort of cause a UGH syndrome in these patients. And please don't forget to create a vitrector peripheral buttonhole iridectomy, because this is going to cause a pupillary glaucoma if you're not going to do a good iridectomy. So see that your pupil is circular, because if there is a sort of a cat's eye pupil, then you have tucked the iris at the base. So if you have a central circular pupil, the IOL stays like beauty in the angle. It's an angle supported IOL, and there is no touch either to the endothelium or to the iris causing chaffing. And we have a study of almost 20 years of these patients who I'm following up in my practice and in the medical college, and their cornea stayed pristine clear in these patients. That's the iridectomy. So again, I want to say an AC IOL iridectomy is mandatory. So this is, I think the Cyrus had kept the topic of IOL explantation also. So this was an opaque IOL. You can see that there's a bag with the IOL. I was planning that I will remove the IOL and then I'll put a secondary IOL in the bag. But you see that these bags are so fibrosed with the IOL ensconced in the bag like a cocoon. So in this case turned out I had planned so many things that I'll just remove the IOL, cut it, I'll prolapse into the AC, but it was impossible to dissect the bag from this IOL. We'll learn the tricks from Cyrus. He has done a lot of these explantations of IOLs, but unfortunately the bag with the opaque lens came out and I had to remove it in toto, you know. So you'll see this. So this is how we had to explant the lens in toto, we had to do it. So once you get the IOL out, then it comes out beautifully from the wound itself. So there's no big problem in that. And then again, in this case, I inserted an anterior chamber IOL, which gave a very good result in this patient. So this is like a trapdoor iris claw subluxation management, where one of the haptics unfortunately gets, disentangled from the iris, and it's like a trapdoor hanging down with the IOL vertically floating into the mid-vitreous. So this is how we did it. Sorry, I'll just go back. So you make a 3 pass planar openings of a 23 gauge vitrectomy. Use your vitreous cutter to sort of levitate the IOL vertically from there, because the infusion is coming from the other direction. It was nasal where it was lying there. So the infusion pushes up the lens. Then you support the IOL with your cutter from behind. Open your incision. This lens requires to be held very well with a forceps to get a steady grip on the IOL, because you're going to sort of enclave the other eye. So you require a good counter. So this is I had unfortunately didn't have the Shepherd's forceps, so I'm using a Kelman-Macpherson, and here I'm making sure that I'm enclaving it. So you can see the enclavation has been done so well that almost I have caused a rupture in the iris. Yeah, so you can see actually the enclaved haptic here very well. So this was unfortunately done on my colleague's father, who had a subluxated bag. So after that, please don't forget to do a very good anterior and a mid vitrectomy. So we have this pars plana openings from where you go and do a good vitrectomy and release all the vitreous around. In an iris claw IOL, I don't feel it's necessary to do an iridectomy in these patients if you have done an adequate anterior and mid vitrectomy. So again, I'm going through the side port and doing a good vitrectomy, getting all the vitreous wicks and all the vitreous stuck out, so you get a round and a central pupil in these patients. This is a total unedited movie I wanted to show you all once, and that's the pupil which gets circular. In this case, I did a peripheral iridectomy because this was doctor's father who was operating the second time, to be sure that we don't have a problem. And the end result was very gratifying. This again, I wanted to show you this point where you go from the pars plana and do again good anterior vitrectomy. And in the end, the eye looks beautiful. So remember the rule in any vitreous surgery or any complex IOL drop, the first thing to go in is your infusion cannula, and the last thing to come out is your infusion cannula. So first in, last out rule remains. So because the eye gets very soft, you can see, and that's the pars plana approach to do a good mid vitrectomy, which I've done. Now this is my favorite baby which I've got now. It's called as any single piece foldable IOL can be made a scleral tuck IOL, which Dr. Niven presented. So PCR and vitreous loss always comes unannounced. Anterior vitrectomy is done, but there's poor posterior capsular support. You can't keep a battery of IOLs every time, for every case which you have. So you need a method where any single piece IOL can be converted into a scleral tuck or a transscleral fix IOL. The principle is to create a transscleral plug on the haptic for scleral support. So you can deliver what you promise to your patient. The premium IOL syndrome, which we are, I think, transferring to our patients nowadays, trifocals, EDOFs, toric IOLs. Yeah, so this is you have a normal 12.5 IOL, and the ciliary sulcus is 11. So a stretched haptic with a plug is of the ideal size. Like the Nivean's lens is around 13.75. So this is the idea I got from the Carlevale lens, which I was studying about, to get this idea. And CMT Flex is our Indian version of the same lens. So what you require, you have this IOL which you're going to insert, and you just require 4050 Prolene in this patient. So what you do is a single piece IOL design with Yamanization haptic dumbbell creation with a 50 Prolene. So this is how the IOL will look once you have created it. This can be created in the OT with 5 minutes time. This is all you require. The surgical technique is the same. Mark 3 and 9 o'clock with limited peritomy, angled sclerotomy with 23 gauge MVR with a slight tunnel, as Nivian said. Flanged IOL plug is inserted over the IOL, and each transscleral plug is exteriorized with a max grip forceps, and the laxity adjusted with the 50 Fluorine lock-in suture, and the peritomy is co-opted with diathermy. So this is how we create these transscleral dumbbells. So this is a 3-piece Orolab lens with a hole in the haptic, okay? So I have passed my 50 Prolene through the haptic, cut it, and I'm creating 2 dumbbells here, as you can see. You can use the heat cautery, or you can use even this. This is your IOL which is ready, okay? So this is the IOL with 2 dumbbells which you have created in the OT that time itself, yeah? So this was the case now. This was my first transscleral tuck IOL, which I call it. So this patient, as all scleral support IOLs we used to insert with 10-0 Prolene. After 10 years, that Prolene degrades and this falls down. So this was a scleral support IOL which had fallen down with the vitreous. So I did a vitrectomy and I got this IOL out. And this was my IOL which I'm creating. Okay, this is a normal single piece IOL. This was my first case, and this needle looks very giant, but I found that if you have a round body needle which is available with 6-0 Prolene, it's ideal. So you pass this needle through both the haptics, and then you cut off the suture, and you create a similar dumbbell which I showed you in the previous video, by Yamanizing it, by creating this dumbbell with the heat cautery here. So now you have an IOL, a foldable IOL with 2 dumbbells on each side, okay? You can fold this IOL and inject it with the same injector which you have, dump it over the iris, and then through a side port incision. I was so excited that the video is not. See, this is how you exteriorize the haptic, as you can see here. So one haptic is out with the dumbbell. The second one is also out with the dumbbell. And then you further dumbbellize it, as Sir was saying, by extra cautery, and shove it in that tunnel which you have created. So this is your, any IOL becomes a transscleral plug IOL. And as you can see, my infusion is still there. It's the last which is coming out. So this was another brief procedure I'll show you all. Again, the same thing. So this is a single piece IOL because there is no iris, so you can't put an iris claw here. You can't put an AC IOL. There's no iris at all there, So this is the one dumbbell which comes out. Then similarly, the second dumbbell. So the forceps which we use is called as the retinal 23 gauge max grip forceps, and you're using a handshake maneuver for the trailing haptic. So you push it in the AC, and then you use it from the side port. You can exteriorize it. This is the unedited version I'm showing you, so just bear with me. And now I think I've managed to get it out. So just feed it out and then it comes out. And then you shove it into the groove which I said, which you create after further sort of dumbbellizing it, and then you're done with the surgery. And the centration is beautiful. I had a lens tilt in few of these patients of mine, I won't deny that. But then it's not a very visually significant problem. So this is how the post-op looks like. This is again a brief video of AC IOLs. Means I just wanted to share with you all that this is the IOL to go to, which can be over in 5 minutes, and it gives very gratifying results. If you have done a good anterior vitrectomy, that is the main point I want to share with you all. And again, please use an infusion. If you're not safe with a pars plana infusion, please use an AC maintainer. And always dial the haptics by flexing them. You can't dial it how you dial a PC IOL in the sulcus. So we flex it and we dial it horizontally always. So this is one last video I'll just request Cyrus to give me. So this is again, I'm inserting an IOL, a foldable IOL in some residual capsule which was left behind in this patient with vitreous loss. So this is my, you know, if you put your leading haptic first, it goes through that 6 o'clock dialysis and falls inside. So this is the technique I've said, that you find where the residual capsule is there and use your trailing haptic first technique, where the trailing haptic goes over the residual capsular complex, and then you can dial the leading haptic safely away from the area of dialysis where the lens doesn't fall back again into that crevice which is there at 6 o'clock when you're trying to inject. So this I describe as a trailing haptic technique. And then now with the trailing haptic behind over the capsular bag remnant, you can dial this lens, and the leading haptic which has now become the trailing haptic can be dialed back into the place. This is on an open posterior lens capsule. You can always inject a PC IOL over the iris and then dial it carefully into the